from the P more or less to the Q or R there, onset of the P to the Q or R, we're going to, when we talk about the cardiac cycle, that corresponds to ventricular filling. Here they're calling it atrial contraction. That's correct as far as this portion is concerned, but it really corresponds to the period of time required for the ventricles to fill. And then here's our depolarization. Here's our myocyte depolarization down here. And then notice the interval approximately from the Q to the T is going to correspond to ventricular contraction. We've indicated that to a large extent, that's going to be determined. This isn't necessarily drawn to scale, but that's going to be determined by that plateau phase. And let's defer a consideration of this because we really haven't talked about the Wiggers diagram yet, so we'll come back to that a little later. All kinds of information that you could that an experienced technician, cardiologist can derive from the EKG. I've listed a few here. Now we've already fought the battle of rate and rhythm. Everybody understand the distinction there? You have a heart rate of 60. Those 60 beats may occur in the last 10 seconds, right? Nothing. Think you're dead, and you're good to go. But also conduction efficiency, we've talked about dromotropic and chronotropic effects, a lot of things that can affect that. We'll talk about blocks in just a moment, a little bit about blocks. Conduction velocity, velocity is distance over time. And that too would be a function of dromotropic factors. You can even, an experienced individual can even make estimations about the mechanical performance of the heart. Perhaps if there is too little or too much potassium, we've already talked about, for example, how calcium levels, hypocalcemia, can influence the heart. So again, there may be a characteristic signature in the EKG.
On this animation,
Don't look at the animation.
The one on the right, the one with the left ventricle looks like there's all
Oh, you're talking about the alien waveform creature here. No, you're certainly, we're going to find out there's something called insystolic volume, which all of the blood is not pumped out of the ventricle. As to the correspondence between this picture and what we're looking at, does anybody want to? All right. So what we're going to find later, as we talk about the cardiac cycle, is just be sure you understand not all of the blood is pumped out. There's going to be quite a bit remaining. We have talked about these terms, tachycardia, bradycardia. There will be clinical definitions, and we'll talk a little more about this as we talk about the cardiac cycle. Let's just say for our purposes in here, tachycardia is a heart rate greater than 100 beats per minute. Bradycardia is less than 60 beats per minute. It's going to vary with a lot of factors. Arrhythmia implies what? Do you mean by arrhythmia? Or an anomaly in the rhythm. For example, would tachycardia be considered arrhythmia? Yes. So it could be an accelerated rhythm, a depressed rhythm, or an abnormality in the rhythm. Again, we talked about the difference between rate and rhythmicity. Fibrillation just implies that the rate of contraction, the rate of contractile myocyte contraction is non-productive. It is so rapid that a sufficient volume of blood is not being discharged either from the atria into the ventricles or from the ventricles into the pulmonary trunk or the aorta. The rate of contraction is both rapid and non-productive. We'll look at examples of that in just a moment. And we'll talk about a block too in just a moment. A block implies some insufficiency of conduction between the SA node all the way down to the myocardium. That interruption in the conduction of the signal from the SA node to the ventricular myocardium can occur at several points along that pathway. So this would be a normal EKG. I'm not going to ask you to interpret all the components of this, but again, what I do want you to be able to tell me is what those things mean, what that is, and what these are. about that. We talked about at least the theoretical derivation of them. And then usually there'll be another one down here that is used as your reference. So at the top there, we have a normal EKG, and we're going to talk about blocks in just a moment. This is a third degree block, but in that illustration, before we get into that discussion, what is abnormal about this? What is abnormal about this EKG? What do you notice that doesn't look right? All right, you have many more P's than you have QRS complexes. So what would that suggest in very general terms? All right, so there must be some disconnect, and we'll talk about that in more detail, some fundamental electrical disconnect between the atrium and the ventricles. Talking about fibrillation here, this is atrial fibrillation. The therapies and the ways of addressing that seems to be changing daily, and that too is going to be a function of your patient. You're going to treat elderly diabetic patients differently probably than you would a young healthy patient. But in atrial fibrillation, again, we need really more information. We need to talk about what the function of the atria are, but the atria are going to be basically contracting just enough to push maybe 15-20% of the blood that enters the atria into the ventricles. And it's not a big amount. We won't talk about it too much in here, but what is the real risk? What is the real danger in atrial fibrillation? Because it's not usually getting the blood to the body or the heart. Blood to the body or the lungs. What's the real problem?
Clot formation?
Yeah, it's usually thrombogenic, and so sometimes medications or other therapies have to be implemented to prevent formation of clots. The atria have, in some cases, have little pockets in there where the blood can coagulate. If it just rests there, you have a tendency to clot, and those clots can be propagated to either the lungs or the other tissues. This is serious, so this could be fatal. This is ventricular fibrillation, and the idea here, once again, is very, very rapid, abnormally rapid contraction. It is insufficiently productive. There is an insufficient volume of blood leaving the ventricle either to supply the lungs or the body tissues. All right, let's talk a little bit about blocks. In our simplistic representation, we're just going to talk about first degree, second degree, and third degree. And a first degree block, the implication is there's some delay in getting the signal from the atria to the ventricles. So it's just slowed up. Usually, it can be variable. Oftentimes, the delay between the atrial signal and the ventricular signal is consistently slow. So if you look up here at the EKG, you can see the QRS there, again, if I can draw. And so where is the P wave here? Good. And so the implication is that this interval here is a little longer than it should be. I'm quite proud of myself for having done that. But that's what we imply by a first degree block. Now, if you look at the second two here, we have a second degree block here and a third degree block here. Now let's look at the second degree block. Any abnormal? What do you notice in this EKG that's abnormal? Go ahead. All right, so the bot says there's not a QRS for every P. Here's a P, and we have a QRS. P with no QRS. There's a P. So again, there's a problem with the signal being propagated from the atria to the ventricles. But what you will notice, and Bob or Abby can quibble with me about this, and we're just going to approach this very simply here. What you'll notice is that where there are P's followed by QRS, notice the temporal relationship. So in those right there, would you say that the distance between the P and the R in each of those three cases is roughly the same? All right, so that's characteristic of a second degree block in our simplistic discussion. Now let's look at the third degree block down. Remember third degree block? Yeah, go ahead.
Just to make, we're not doing vocals or anything.
No,
right?
no, we're just getting, let's not, this isn't a pathology course. So if you notice here, we have lots of P's that, without corresponding QRSs, right? But in this case, you look at one here, look at one there, look at one there. Is the distance between the P and the QRS always equivalent? No. So in a third degree block, pretty much what's implied is the atria and the ventricle are just going their own separate ways. Complete divorce. Somebody's moved out, taken all the furniture. They're completely autonomous, and that's the primary difference. You have some level of communication here. Nothing, no significant communication in the third degree block. Again, an illustration of atrial fibrillation. You can see the QRS with these little squiggly lines of the atrial fibrillation there. And we won't worry about the. I just threw this in because as you evolve as a PA, these are the types of things you will be able to diagnose simply surveying the EKG. Probably seen these things. Technology is changing. We don't even need EKGs anymore.
Hello, this is Dr. David Albert, and today I'm going to give you an update on our AliveCore iPhone and new iCard ECG.
So I'm going to skip
quickly
here. What he does,
years of use
he
before
takes
you
his
even
iPhone.
change the battery. And this device is essentially a universal device. So unlike our iPhone 4 case, this one can work with an iPhone 3GS. And here is an iPhone 3GS. I happen to have borrowed this from one of my children. And here's our iCard ECG, and I'm going to place this on the back. So now you see the iCard ECG. Again, it's completely hidden by the front of the iPhone 3GS. I'm going to turn it on. And like our iPhone ECG, we now have
Can you see the display?
let's see here. There we go. And now you can see through my cotton polo shirt with the iPhone 3GS, I'm recording without pushing any buttons. All I did is start the app. I'm recording my ECG.
And the iPhone interprets it.
Very clean, identifying beats.
And as the
So that
experts in here will
this
tell you,
device,
the EKG interpretation that you get from the devices is always correct. There's never any issue, right? So I don't know. Anybody familiar with these? They're fairly inexpensive. Oh, so I get just something to think about. We talked about what's the difference between a pacemaker and a defibrillator? Anybody? Right. If the other ones, the patients describe it as being a thunderbolt in their chest. It simply takes the heart out of a condition of fibrillation. We pointed out that we've talked about the fact that the SA node normally generates the most rapid frequency of excitation, and that frequency decreases. So a lot of times the pacemaker is required for ectopic excitation or because of some other reason. There are all kinds of new ways that the pacemakers can be introduced. There's even a
development that could be a big game
recent
changer
procedure
for
in
heart
this.
patients. About 200,000 cardiac pacemakers are implanted every year in this country.
And now a new version is being tested, and it doesn't require surgery. CBS News' Dr. Max Gomez shows us how it works.
Researchers at Mount Sinai Hospital were the first in the U.S. to implant this new experimental pacemaker, smaller than a AAA battery.
This device doesn't require surgery, so that means there's a low risk of infection.
Doctors use a catheter to guide the new device up through a vein in the leg and screw it directly into the heart muscle. Doctors say the new pacemaker doesn't have wires or leads, which may be another advantage.
The problem is if ever that lead has to be removed, then it's very difficult to remove that lead. It's also a problem because that lead, which is what communicates with the heart, that lead can fracture.
Pacemakers are necessary when a patient's heart doesn't beat fast enough or beats erratically. Dr. Vivek Reddy says the procedure only takes 5 to 10 minutes, and the recovery is quick too. The device correct.
Boy, that's what it turns you into. I think I'm going to delay my surgery if you don't mind. But there are even biological pacemakers. Am I familiar with the biological pacemakers? The simply culture the cells that are generating the rhythm at the correct rate and implanting those. I don't know how long that technology is. A lot of new exciting therapies out there. All right, so I've been threatening you with the discussion of the cardiac cycle, so let's move on to that discussion. We've already established it at our initial meeting on this topic, that the primary function of the heart is to establish the central pressure gradient. Now we need in any type of rheological system where we have flow of fluid through tubules. In order for that flow to occur, there must be a pressure difference. So the heart, first and foremost, establishes the necessary pressure difference or pressure gradient for the blood in the body to flow either through the lungs or through the body. So the trouble with American English, I guess this is true of other British English as well, is that we use the term flow in a variety of ways. We can talk about flow rate, which is kind of redundant. But in general, you should understand flow to refer to an amount. You can be either an amount in absolute terms or an amount over time. Technically, it should refer to the amount over time. And once again, that flow is going to be dependent upon the pressure. Just as we talked about in diffusion, and will come up again in our discussion of pulmonary physiology, the flow is always from high pressure to low pressure. By the cardiac cycle, we're talking about the peculiar method by which this pulsatile heart generates the pressure. The heart, the atria and ventricles undergo systole or contraction, and then a diastole, which is relaxation. As this happens, we talked about the fact that the AV valves and the semilunar valves initially have to open and then close. Remember, they're generally, one pair is going to be open while the other is closed, and so on. The valves open only in one direction, they're unidirectional valves, and they open exclusively in response to the pressure gradient. We're going to find that the pressure on the left side of the heart is substantially greater than the pressure on the right side of the heart. Consequently, if you have let's say a child with a ventricular septal defect, what is a ventricular septal defect? What does that mean? VSD. All right, there's an opening somewhere between those two ventricles, between the right and the left ventricle. Let's say you then have a child with a VSD. Would you expect the blood to flow, under most cases, from right to left or from left to right? Which way? Left to right. Right. There are some points at which that doesn't occur, but we won't worry about that. All right, so the left side of the heart, as we talked about before, is pumping the blood to the entire body. The right side of the heart is pumping the blood to the lungs, a much smaller volume. So at any given time, which side of the heart is pumping more blood, the right or the left?
Left.
They're equal. Don't let me trick you. Well, go ahead, let me trick you every now and then. Like, let me win the chess game every now and then. But make sure you understand that it wouldn't be appropriate for one side to pump more than the other. The volume of blood pumped through the right and the left sides has to be equal. In fact, if that doesn't occur, then you have significant issues. And we'll talk about the ejection volume and the stroke volume in just a moment. So this is an important illustration. I would encourage you maybe to print this one out or enlarge it because you need to know this thoroughly. There are some problems with this particular illustration, but in general, it will serve our purposes. And this being a cycle, this being a cardiac cycle, we can begin at any point. Let's begin at the top there. And what is shown there is something called late diastole, in which the blood is passing from either the vena cava or the pulmonary veins into the atria. So the blood's moving into the atria, and from the atria, the blood is passing into the ventricles. Now, we know that flow occurs only in response to what? What causes flow to occur?
Pressure.
Pressure. So that if that's true, if blood is passing from the atria to the ventricles, where must the pressure be greater? Greater in the atria or in the ventricles? Atria. Everybody understand that? So the atrial pressure at this point is going to be greater than ventricular pressure, otherwise that valve, that AV valve, would not be open. All right. Now they're calling this late diastole. That's sometimes called the atrial kick, where they're actually making a distinction. Toward the end of this process, of ventricular filling, the atria will contract. Again, that's what we sometimes call the atrial kick, to slightly increase the volume of blood that is introduced into the ventricles. And as that's occurring, as that atrial contraction begins to dissipate, the ventricles begin to contract. And as they begin to contract, the pressure in the ventricles tends to increase. And as ventricular pressure increases, notice those AV valves close. In fact, if you look at that illustration, I don't know if you can see it there, but as you look at the illustration, what do you notice about the semilunar valve? Is it open or closed? All right, so what you should know, we're entering a period here called isovolumic ventricular contraction. All the blood that is going to be delivered into the ventricle is now in the ventricle. That's called end diastolic volume, EDV. And we'll say it's about 135 mils, just as a point of reference. Now, as we've indicated, in isovolumic ventricular contraction, all the valves are closed, but the ventricles are contracting. So one of the peculiar consequences of this state of affairs is that the pressure in the ventricles is increasing. What does ISO mean?
Same.
So what's happening to the volume of the ventricle? We're only talking about the ventricle here. What's happening to the volume of the ventricle as the pressure is increasing in this phase?
Doesn't change.
It does not change. So make sure you understand that. In the isovolumic ventricular, or sometimes you'll see isovolumetric ventricular contraction phase, the pressure in the ventricle is increasing, the volume does not change. Ever heard of Boyle's law?
Yeah.
What's Boyle's law?
One of the gas laws.
Huh?
B1 equals B2B.
I always say that. That's really a conservation principle. People, Boyle's law, you can get there. You can get that from here, but Boyle's law tells us there's a relationship between pressure and volume. What's the relationship?
Inverse.
It's inverse. Yeah, exactly. As one goes up, the other goes down. Why isn't Boyle's law relevant here? Well, it is constant, but why? Because the pressure is changing, pressure is going up. Why is the volume constant?
Because the pressure in the atria and the pulmonary arteries isn't high enough, low enough yet?
No, so the valve is closed, so we can't get blood back into the atria. Well, if you get blood back into the atria at this point, the patient's in trouble. We'll talk about that later. That would be some type of valvular problem. So make sure we have a contained volume. Volume's not changing with the pressure going up. Simple answer is, yeah, go ahead.
Well, if the volume were blood's changing the constant pressure, then it would never go through the valve. So if it would compensate for itself and stay in the same chamber.
I agree with you. That's
The volume stays the same, and then the pressure changes due to external, like the contraction of the muscle, more so than the volume.
okay. I agree with your premise and conclusion, but I still want to know why Boyle's law is invalid here. It's the same reason that when you step on George.
I don't know, I thought that oils have to do just with gas.
Exactly right. But I can't tell you how many times on test or at the end of the course somebody brings this up. So make sure you understand Boyle's law refers to gases. Fluids are incompressible. And you need to appreciate in our discussion of cardiovascular physiology that fluids are incompressible. This is why when you step on the brake pedal in the car, your brake caliper is closed because it's a fluid that's acting like a lever. They have hydraulic clutches too. They have a straight drive. All kinds of these, all of these. When the fellow comes to pick up the trash and put it in his truck, all of that's driven by hydraulics. Same principle here. So make sure you understand that pressure can increase without volume changing, and that's what happens. Now, eventually, the volume is going to increase to a point that one of these valves opens. Which set of valves is going to open first? The AV valves or the semilunar valves?
Semilunar.
All right, so the semilunar valves will eventually open in response to the pressure gradient. So at that point, in order for the blood to move from the ventricle, we'll just use this looks like the trunk here, but we'll use the example of the left. If the blood is moving from the ventricle into the aorta, where is the pressure higher, in the ventricle or the aorta?
Ventricle.
In the ventricle. All right. So remember, in order for flow to occur, there has to be higher pressure in the ventricle than in the aorta. Yeah.
Those semilunar valves, they have some muscle attachment to space shut.
The semilunars do not. Only the
Keeping
AV.
them shut while pressure.
All right. So Luis is asking, what's keeping? Let's go back to this one. So in the isovolumic phase, all of these valves are shut. All right. So let's work through it. What caused this valve to close? What caused the AV valve to close? Pressure. So the pressure now in the ventricle is greater than the atrium. This valve only opens in one direction. If pressure goes in the opposite direction, what does it do? It closes. All right. In this case, the valve is closed as well. We know that in the next phase, the blood is going to leave via that opening. But in this condition, where is the pressure greater? Here or here? Is it going to be greater in actually, let's go over the aorta again, since that's easier to understand. When that valve is closed, when that aortic valve is closed, is the pressure higher in the aorta or in the ventricle? Aorta. So it's aortic pressure that keeps it closed. And of course, if there is backflow, once again, that's a real serious problem. Remember that principle, the valves allow for flow to occur in one direction, and they open only in response to a pressure. So now in ventricular ejection, the pressure in the ventricle is greater than in the aorta, and blood is then going to be discharged into the aorta. And you can see here, at some point, the ventricular contraction is going to be arrested. The flow of blood will stop, and the volume of blood remaining in the ventricle is called the end systolic volume. And we'll say that's around 65 mils. So as we pointed out earlier, not all of the blood that's present in the ventricles is going to be discharged. But I bet you can calculate how much was discharged into the aorta. How would you do that? Yeah, you would just subtract this volume from that volume, and that would tell you what?
Volume.
The volume that is discharged, and we're going to call that stroke volume. Everybody with us to this point, again, just to make sure you understand the relationship between these volumes and the pressures. The pressures are the most important thing. And this is the phase that always gave me the greatest trouble, because I had trouble understanding this relationship between pressure and volume in fluids when I was young. But now we enter what's called the isovolumic ventricular relaxation phase. Isovolumic ventricular relaxation. What you notice again is all the valves are closed. In the isovolumic phases, all the valves are closed. And you look at the state of affairs here. What's happening to the pressure in the ventricles during the isovolumic ventricular relaxation phase? What's happening to the pressure in the ventricles? Is it going up or going down? Down. What happens to the volume of the ventricles as the pressure is decreasing? Stays the same. All right? So what I want you to be able to do is tell me where the pressure is greatest in this relaxation phase, this isovolumic relaxation phase. Is it greater in the atria or the ventricles, or for example, between the ventricle and the aorta? So all the valves are closed. So if in this phase, is the ventricular pressure higher than atrial pressure, or is atrial pressure higher than ventricular pressure? All right, Evan says the ventricular pressure is higher. Why? How do you know that? So, but why do you make the assumption? Well, if this valve is open, what must that mean? Does everybody see that? So the only reason this valve is closed is because the ventricular pressure is greater than atrial pressure. Otherwise, the blood is going to be flowing from the atrium to the ventricle. And then eventually that takes us back to where we began, the late diastole with ventricular filling. And so at some point, the ventricular pressure is going to drop. As the ventricular pressure drops, eventually it drops below atrial pressure, the AV valves open, and we get diastole, we get ventricular diastole. Any questions about the general sequence of events in the cardiac cycle? Let's turn then to an illustration of the relationship between the atrial and ventricular pressures. This is called a Wiggers diagram. You need to know, you need to be very familiar with the Wiggers diagram, and you have several in here. You have this one, and you have a couple here. But let's work through it. In the Wiggers diagram, we have, first of all, a pressure graph. These graphs are somewhat separate. We have a ventricular volume graph down here and a pressure graph here. And notice in the pressure graph, we go from 0 to 120. What is the 120 all about? Is that? All right, systolic pressure. We say your blood pressure might be, normal blood pressure might be 120 over 80, for example. You might want to be thinking about those numbers. But I just want to make sure you see that the pressure is increasing in the vertical axis here. And this is time, the horizontal axis. So if pressure is increasing in this direction as we move up, if a line, such as the black line here, is above another line, what does that mean? The line that is higher must be at a higher pressure. Now in the illustration of this Wiggers diagram, the atrial pressure is blue, the ventricular pressure is red. So what do you notice about the relationship between atrial pressure and ventricular pressure for most of the cardiac cycle? Which is greater?
Atrial.
Most of the cardiac cycle, which is greater, atrial pressure or ventricular pressure? Atrial. All right, so make sure you see that. That's kind of counterintuitive, but atrial pressure, certainly during diastole, which is most of the cardiac cycle, the majority of it, is greater than ventricular pressure. It's true over here. Atrial pressure is higher. Then at point 3 here, they intersect, which means the volumes are equivalent. And what happens there? The AV valve closes, right? Ventricular pressure, the AV valve was open because atrial pressure exceeded ventricular pressure. Blood was flowing from the atrium to the ventricles. The ventricle now starts to contract. The pressure in the ventricle increases, and that causes the AV valve to close. So that's what happens here. What's this vertical red line here all about? Right, so pressure is going up dramatically. Let's look at so here's the volume curve down here for the left ventricle. Let's sort of come right straight down here. What's happening to ventricular volume as the pressure in the ventricle is increasing? Does it change? No, this is the isovolumic phase. So volume does not change as pressure is increasing. By the way, the black line is the aortic pressure. So what must happen right here? They don't have a little number there. What's happening right here? The red line is the ventricular pressure, so now the ventricular pressure is greater than aortic pressure. So that means that at this point, as long as that red line is on top of the black line, what must be happening? The blood is passing from the ventricle into the aorta. Then the ventricle is going to get a little bit tired here. It's going to get a little bit weaker, and these pressures tend to coincide until eventually the ventricular pressure drops sufficiently that now the aortic valve closes. And so after this point, between 6 and I guess they're calling that 8, we'll call this 8 here, the ventricular pressure is dropping, but again, let's come down here to the volume curve. What happens to ventricular volume? Does it change during that period? So what do we call this period right here? Isovolumic relaxation. Over here was isovolumic contraction. Whoops, I did it again. Isovolumic contraction in there, and then isovolumic relaxation over there. And what are the characteristics? Somebody quickly summarize the characteristics of the isovolumic phases. What's always going to be true? What about the valves? Oh, closed. What about the volume of the ventricle? Doesn't change. And pressure does or does not change? Changes, right? Either going up or down, depending upon whether we're talking about contraction or relaxation. And then eventually the pressure is going to drop to such a degree that it's now once again below atrial pressure. And when the AV valve opens, the blood rushes in from the atrium into the ventricle. And once again, atrial pressure in diastole is consistently greater than it is than the pressure of the ventricle. When you come down here to the volume curve and you see the line increasing, this red line increasing, what does that mean? And why? So I see it increasing here, it's still increasing over here.
Ventricle filling.
All right, ventricular filling, because the pressure in the ventricle is, the pressure in the atrium is greater than the pressure in the ventricle, so blood is flowing from the atrium into the ventricle. The ventricle is filling with blood, the volume is increasing. But during systole, the blood is discharged. Make sure you understand EDV and ESV. What is the definition of ED in diastolic volume? That's the volume in the ventricle at what point? Right, prior to contraction. And we could also say that at the end of relaxation, when basically all the blood is going to pass from the atria to the ventricle has been discharged into the ventricle. And then what is end systolic volume? Exactly right. That's the volume remaining in the ventricle following the ejection, following systole. And remember, in our little simplification, that's going to be about 65 mils. Any questions then about the relationship between these pressures, the atrial pressure? Everybody understand how to read a Wigger's diagram? Yeah?
Yeah, aortic valve opens when pressure is bigger.
Yes, when the ventricular pressure exceeds aortic pressure, the aortic valve opens. And it will remain open. This is a little bit deceiving here, but it will remain open until aortic pressure is greater than ventricular pressure. Remember, all these valves open in response to pressure in one direction only. Yes, sir.
So is early ventricular diastole the same as isovolumetric relaxation?
Let me see what you're.
On the slide before.
Oops. This one. Which one are we talking about?
That one.
All right, and you're looking at.
So the pictures of the heart there, it says early ventricular diastole.
And you're asking if that. All that means is there's what's called passive filling. In early ventricular diastole, the implication there, and I'm not sure that this is. I see what you're saying, that this little arrow here is that's the same. Technically, early ventricular diastole just means that the pressure, let's say it's in the vena cava is greater than the pressure in the ventricle. And so blood will simply flow through the atrium into the ventricle. No, I would say that if your question is, does that correspond to early ventricular, does the isovolemic relaxation correspond to, yeah, I don't think that would be true. Because ventricular diastole, the problem in isovolumic, the isovolumic phases is the valves are closed, so there can be no filling. I don't know how you have such eagle eyes to see that sort of thing. Good job. All right, so this picture, this particular Brigger's diagram is a little more complicated. In addition to the relationship between the EKG and the events of the cardiac cycle, you can see the EKG up here. You'll also notice S1 and S2, which they're labeling the heart sound. So as you look at S1 and S2, do they label them here? Yes. Well, let's go to this one. To what do the two heart sounds correspond?
Isovolumic.
Well, is it the valves opening or
Closing.
Yeah, the valves are closing. With the atrioventricular valve, and then in S2, the semilunar valves would be closing. Anything else we need to sort through here? I think so as long as you understand the relationship between volume and pressure in the Brigger's diagram, you should be good to go. All right, let's. A lot of these remaining slides just deal with the concepts and terms. For example, you should know the definition of cardiac output. Cardiac output is simply the product of heart rate times stroke volume. So, for example, if your heart rate is 60 and your stroke 60 times per minute, and your stroke volume is 60 milliliters, what would your cardiac output be? 60 and 60, just to make it simple. Yeah, 3.6 liters. So that's all that is. Very, very simple. And we're going to now sort of dissect the components of the cardiac output. We've talked about the stroke volume being the amount of water volume blood discharge from the ventricle. The stroke volume plus the ESV is going to be equivalent to end diastolic volume. So you should be able to do that arithmetic. The stroke volume clinically is going to be affected by a variety of different things. You can see here quite a significant range. The age of the patient, the size of the patient, the relative fitness, whether the individual has heart disease or perhaps is just a trained athlete. We're going to talk about preload and afterload, if the heart responds to preload and afterload properly. And then the heart rate, I've indicated the typical rate is typically around 75 beats per minute. As we've indicated, it normally anywhere from 60 to 100, independent of any type of exercise. With exercise, you can see that the heart rate can peak at around 150 in healthy young persons. I don't think I would sustain that, survive that very long. Stroke volume typically peaks at around 130 mils. So if you do the arithmetic there, my goodness, you get a fantastic cardiac output, which you would see in perhaps a trained bicyclist or marathon runner or whatever. Look at number 2 here. We've already talked about the first 2 points. It says cardiac output changes with circumstances. Just be aware of some of the factors that might influence cardiac output. This is something called orthostatic hypotension, standing from a recumbent position. So if I'm lying down, maybe some of you have done this perhaps after lifting weights or whatever, you're lying on the weight bench, you get up very quickly and you get a little dizzy, a little black tunnel vision. What's that all about? What's causing that? What's the
Reduced ejection.
I'm sorry?
The reduced ejection fraction. You kind of get a little lightheaded.
Okay, but why? What's happening to cause that? You're lying down and your heart is, going to be on this plane on the ground. So your heart's only trying to overcome this amount of gravity. It's pumping laterally. That's a mechanical resistance, hydraulic resistance. But the gravitational load is rather small. Now, when you stand up, the heart has the increased workload of doing what? Pumping blood up to the head and also getting that blood that's now way down here back up to the heart. You know, that musculatus pump foolish has to deal with as well. So the primary problem here in orthostatic hypotension, the drop in blood pressure, is caused by the increase in the gravitational vector. How does the body respond? How does the normally respond to that? How does the body compensate? What keeps you from passing out? Yeah, and what system kicks in to increase the heart rate, increase the cardiac output? Yeah, the autonomic nervous system. Sleep will lower cardiac output. Unless, like me, I think about coming to this class each day, and I go into night terrors, and my cardiac output goes up dramatically until eventually I wake up in a cold sweat and seek solace in classical music or something. Fear, large meal elevates cardiac output. Odd that I would put those two together. Look at this. Pregnancy slowly elevates cardiac output by some 40%. Just a tremendous burden on the physiology of the mother. I know we've talked about the strenuous exercise again can cause a significant change in cardiac output. We're going to come back to autonomic regulation later, but of course what we're going to find that in general is that the autonomic nervous system can regulate heart rate and contractility. So make sure you appreciate it. Later on, we're going to talk about sympathetic regulation. Sympathetic activation can do both. Moreover, there are a number of factors, both autonomic and endocrine, that can regulate the diameter of blood vessels. So, for example, as vasomotor tone, as the arterial smooth muscle contracts, what's going to happen to peripheral resistance? Will it go up or down? Goes up. And what's the effect on blood pressure? Increase. All right. And so, in general, the body tries to avoid simultaneous increases in heart rate and vasomotor tone, because that would be, you'd be increasing the work against a great resistance that would not redound to the health of the heart over a long period of time. All right, we're out of time, so we'll stop there and pick up this on Thursday.